But that's the tip of the iceberg. It really starts again down here with airway inflammation, which leads to bronchial hyperresponsiveness, airflow obstruction, and whammo, the Titanic runs into the symptoms. There are a variety of different medications, and we'll break these down. The most common ones that are used, sometimes abused, are the short-acting beta-2 agonists. As Dr. Friedman was talking, the beta receptors occur in the lungs, the heart, and the blood vessels. The beta-1 receptors are mostly in the cardiovascular system. The beta-2 receptors are in the airways. We're familiar with albuterol, which is the same thing as Ventolin or Preventil. Maxair, a new, relatively new medication. Zopanex is a levoisomer of the albuterol molecule, and it's very expensive. I'm not sure if it really has any benefit. Another type of bronchodilator is Atrovent or ipratropium. This works through the cholinergic system and not through the beta system. I'm not going to spend a lot of time on this, but when we manage asthma, we look into what level of asthma the patient has. If they have mild intermittent asthma, where they have symptoms maybe twice a week or less and have nocturnal symptoms less than twice a month, you can treat them with occasional beta-2 agonists. When their asthma is a little more persistent or more complicated, we step up the therapy with inhaled steroids, even systemic steroids, and we'll talk about some of these other drugs here in a moment. Delivery of the medication is a ongoing hot issue. Most people are familiar with the metered-dose inhalers, or MDI, or puffer, or Wheezaway, whatever you'd like to call them. Albuterol, Atrovent, Combivent, there are a variety of them. These plastic devices are spacing chambers that allow better delivery of the medication into the airways. If we don't get the medication to the receptors in the airways, we don't get much of an effect. Study after study has shown that patients who take the metered-dose inhaler and just take it out of the box and use it get very little delivery or inconsistent delivery of the medication to the airways, and therefore an inconsistent response. These spacing devices will facilitate delivery of the medication where you want it to go. Long-term control medications, the oldest and most well-known are the corticosteroids, such as prednisone or Medrol, methylprednisolone. Others include cromolyn, which is Intol, or Tylade, long-acting beta-2 agonists, such as Ceravent, methylxanthines, leukotriene modifiers are relatively new, and anti-IgE therapy is something on the near horizon as far as being available for therapy. Inhaled corticosteroids are very important in control of the inflammation in asthma. The most commonly used ones in this area: Flovent, Pulmicort, Arabid, Asmacort, Vanseril, Beclovent, Qvar. These all have different forms of corticosteroids that are delivered to the airways for control of inflammation. Systemic steroid therapy with prednisone or methylprednisolone, used for either exacerbations or severe chronic asthma. It's another slide of normal bronchial mucosa. You can see the epithelial cells are lined up in nice little columns, and there's not much inflammation here, just connective tissue. Here's a patient with pretty bad asthma where you see the disruption of the epithelial cells. The basement membrane is thickened, and you see these little dark purple dots. Those are eosinophils, which are those inflammatory cells which are so nasty in asthma. This slide shows the effect of inhaled cortisone on